No, first and foremost, congratulations for this great work. Throws a lot of insight, and it's good that I am not introduced as the Union Health Secretary for the simple reason otherwise what I say will be seen as acknowledgement of government or denial of government. But you mentioned right in the beginning that officers have been attending, and I'm here today. One of the basic reasons why we thought we must listen to this is you can't perpetually ignore something that's a reality. And unless we really look at reality, we'll never find a solution. This is not to say that I have a solution, but at least let's try and think about what is happening. And if you see this paper, the way it's been built in terms of the architecture of the entire story, where the movement has been traced, their existence, their numbers, their legal position, and what they actually do in the field and how they operate. I am not very sure about the numbers yet, but whatever it is, it remains a fact that there are large numbers in rural areas which are actually at times doing a lot of good in terms of being the first line of contact for those who need medical care, and also in many ways doing a lot of bad to the system by not adhering to what we generally call the medical protocol. And AMR was one such thing that was mentioned. Drug-resistant TB is another one that one could add to. But the issue is, why is it that they are surviving or exist? This is an old idea which has been experimented, but let me give you the other point of view of the medical community, the way they look at it. And I'll just cite two examples. In Bihar, we tried an experiment where there's a particular caste which acts as a birth attendant in every village. So when we tried to increase the institutional delivery, one of the things we said is that let that lady come with the pregnant woman to the hospital and let her assist in the delivery, because she's been doing it in the village in any case. So we trained, gave her a toolkit, etc., etc. But then it has to be closed down because it was just not recognized and the medical community did not accept it. I'll give you a smaller example. Recently we issued instructions that every pregnant woman will be entitled to have a birth attendant when she is delivering. The idea in both of these was very simple, that have by her side a person she has confidence in. Make her feel comfortable. But these are ideas which do not fit in anywhere, for the simple reason that only a person who is registered on the MCI's register or the State Medical Council registered can practice and prescribe. So that is the basic problem we are facing. And ma'am, for many more years, the Parliament reply will remain the same. Let's accept that. For the simple reason that everybody is willing to acknowledge their presence, but nobody is willing to accept them. That is also because as a country we do not have an answer to the question whether they are acceptable or not. We first need to answer this question, that are they actually adding value to the entire medical system or are they not? Only if they are adding value is there a case for recognizing them or maybe training them or maybe accepting them in the system. But the fact remains that whether it is these so-called quacks or it is anyone else, unless India creates a mid-level service provider, we will never be able to reach medical service to the last person. Irrespective of how much of effort we make in creating more seats in MBBS or creating more nurses, we are way behind and we cannot catch up. In any case, my own thought, and this is personal, is we do not need an MBBS doctor at the sub-center or the PSC level. To treat a simple cough and fever, I don't think we need such a highly qualified man to be sitting there. So who do we have? There are two options available with us. Either as a system we start working with them trying to take away some of their bad practices, introduce good practices into them, or, as I said, we create an additional layer, an extra thing into the system where we say that these are not doctors, they are not A&Ms, they are somewhere in between, able to tackle certain things. One of the things we've started, and if the experiment succeeds, it will be very good, that we have now started inviting applications from Ayush doctors and nurses to do a special 6-month bridge course, where we not only try and train, but we also assess their capabilities and then try and use them in the field. I don't know if this group of persons that we create will be able to replace the quack. But if you ask me, as a health secretary, I'll say, I'm already struggling with AMR, I'm struggling with MDR, can I allow more of it? But if you ask me, as a person who's standing in the village, who has to travel at least 2 hours to get to a PSC, I would say whatever is available is best. And the biggest problem is that the entire medical community, and to a great extent the government, is not even willing to recognize the problem. I don't think we can solve this problem unless we accept and recognize that we have a problem here. So it would be great listening to the panelists here, and my people would be around. Unfortunately, I am required to rush, but the fact remains that what the good thing that is happening today is, at least we've started discussing this issue. To many, this is a non-issue, and particularly to administration and political class, this is a non-issue for the simple reason that the work is happening, so not many are complaining. And as well, adverse effects, very few get to know, so they don't complain. I mean, both sides. So since you're getting no complaints, there is no reason in that hierarchy to look at it. But if you really want to get over the health problems and you really want to reach out, I think, whether we like it or not, we need to look at it. And at some stage take a decision. We want it or we don't want it. If you take a decision that you want it, then you will have to discuss in what form, how do they add value to the system. If you don't want it, then you have to be very, very stern and say that this is the end of the story. I really don't have an answer, so I'm not getting into it, but I'm extremely happy that this is being discussed. Thank you for listening. One of the reasons perhaps is that from the government side, we've not been able to create the kind of access that should have been there to reach everyone. One of the other reasons is that no matter how much of access you create and what kind of government servant, be it an usher or an A&M, whoever you send to the field, somehow or the other, this community has managed to gain some amount of confidence of the local people. And good or bad, they are seen as companions in times of crisis who can actually deliver. There have been huge amount of talks. I mean, we just heard that we should have shorter courses, better courses, MCI should recognize it. Now the problem is all these things are being tried out. For example, we are looking at a mid-level service provider with lesser degree in, training, let's say the Ayush doctor or a nurse practitioner to get into this kind of a job. But if you honestly ask me, will this actually lead to a situation where we will not have this community existing? I don't think so. Now, ideally, we should have none of this. But then, the moment you say this, the next question is, who replaces them and who performs that function? And that is where the problem lies. One of the things that was being mentioned, let's say, for example,